Hi everyone and welcome back to TiCME. Today I am absolutely stoked to be able to present a tutorial which combines two great loves of mine, surfing and heart failure. I know those two things don't seem very well matched at the start, but by the end of this tutorial I hope that you will understand heart failure so much better than you did before, using waves to understand the principles of the pathophysiology. This tutorial ties in with the last TiCME tutorial, Real Time in Real Life, and it provides an explanation for that patient's symptoms. So if you haven't done it, it's 3 minutes. Go back to ticme.com.au and do that tutorial now, and then you'll be ready to learn all about the pathophys. Righto, so jumping straight into it with normal left ventricular function, the left ventricular preload is always going to be optimized for the LV's contractility to keep the stroke volume consistent. Now remember the Frank-Starling curve, which shows this lovely relationship with a lovely plateau phase where our normal hearts function along, so we can keep our stroke volumes nice and constant when the preload varies. Remember that preload is essentially the left ventricular end diastolic volume, and that is almost the same as the venous return, which comes back into the right heart. In a normal functioning heart, we have minimal LV afterload. What's afterload? It's the left ventricular wall stress. What is wall stress? It's the wall tension, which is a product of pressure and radius, divided by the thickness of the wall. This is really important for later. Remember that a thicker wall will actually drop your afterload. It is often thought about as the pressure that the left ventricle must overcome to eject blood. It is closely related to aortic pressure and mean arterial pressure, but not exactly the same. Remember that the stroke volume is then ejected smoothly during systole, and the coronary arteries are filled during diastole. And what actually happens is there is some elastic recoil from the aorta and major vessels, and a reflected mild pressure wave comes back down the aorta, hits the closed aortic valve at this point, and then passively fills the coronary arteries to supply the myocardium with oxygen. So here's our oceanographic representation of the heart. We've got the left ventricle, which is the ocean itself, the stroke volume, which is the wave coming through, the outflow tract at the beach, and then the aorta is where that wall is. So in normal heart motion, we've got these lovely, smooth, gentle stroke volumes going through the LVOT up into the aorta, and then there's a reflected pressure wave which gently flows back, filling those coronary arteries. Okay, so we're going to move on to a quick summary of heart failure, but before we start, some abbreviations because there are lots used. CHF usually is chronic heart failure, can be congestive heart failure. CCF is usually meaning congestive cardiac failure. ADHF is used a lot more in the literature now. It means acute decompensated heart failure, and there's usually two types of that, the HF-ref and the HF-PEF. And the HF-ref stands for heart failure reduced ejection fraction, with the PEF standing for heart failure preserved ejection fraction. There's also the commonly used LVF for left ventricular failure and RVF for right ventricular failure, and in Australia and the UK, APO meaning acute pulmonary edema. Right, so standard cardiac failure pathophysiology. Patients who have chronic heart failure, congestive heart failure, represent what we would be taught at medical school being the textbook version of heart failure. What happens is a patient develops slowly over maybe weeks intravascular and then extravascular volume overload, and usually it's due to things like a non-compliance with your medication or with your fluid restriction, or you develop an acute kidney injury and suddenly are retaining more fluid than normal. So these patients have a weak left ventricle and right ventricle. They can't tolerate these big changes in preload. So fluid builds up everywhere into the lungs and periphery, and these patients have peripheral edema, they have pulmonary edema, and as I said, these patients generally have symptoms which develop gradually over time. The patient will tell you, I've had a few days or weeks of increasing orthopnea and P&D and ankle swelling. Remember, these guys have got low ejection fractions, and they're labelled as the HF heart failure with reduced ejection fraction. So in this Sri Lankan ocean version of chronic heart failure, you can see that the stroke volumes aren't as big as they were before. They're not being ejected with the same velocity or force, and the amount returning back into the coronary arteries is significantly reduced. Right, so we're into the best part of the talk. We're going to introduce vascular failure. This is the most common way that patients present acutely with pulmonary edema. Patients with vascular failure have usually got chronic underlying hypertension. As a compensation, they develop left ventricular hypertrophy, and remember that thickened LV wall reduces LV afterload through that equation we saw earlier. And they also have thickened arteries, and their thickened arteries have low elasticity. So the patients who present in vascular failure have had a sudden increase in vasoconstriction and afterload. Have you noticed that the patients who present in that flash acute pulmonary edema often come in at 5 or 6 in the morning? It's thought that they've had a redistribution of fluid overnight due to passively lying supine, and then in the morning, as part of our get out of bed and wake up response, they get that cortisol burst with a bit of a sympathetic burst, which sets this cycle into motion. The increase in afterload occurs via the sympathetic nervous system and the renin-angiotensin-aldosterone systems. So this very high afterload which is occurring then causes the left ventricle to have trouble ejecting its stroke volume. And because it's got to work harder, the myocardial oxygen demand goes up. Now, if that's not bad enough, the sudden vasoconstriction increases preload. So now the LV has got more volume to have to deal with as well. And now the kicker comes. The systemic vascular resistance is now rapidly increasing due to this sympathetic turn on causing vasoconstriction. And remember we said that there's that reflected pressure wave that fills the coronary arteries. Well, now it's coming back with much greater velocity and much greater force, and actually comes back early so that the aortic valve is not actually closed yet, and it bounces back all the way into the left ventricle. You can see now we've got a massive problem. Because from here, this reflected pressure wave is amplifying our vicious cycle, because we're now not filling our coronary arteries properly. The myocardium is now screaming out for oxygen. All the time you're getting more hypoxic. The sympathetic nervous system is saying, hey, turn up the heart rate, turn up the blood pressure, we're hypoxic. It's working harder and harder. The afterload's going up and up and up. Suddenly we're hardly ejecting anything from our left ventricle, and it's backing up rapidly into the pulmonary circuit, causing us to have severe acute pulmonary edema. It's really important to remember that patients in vascular failure are not fluid overloaded. They've redistributed the volume that they had. They're usually euvolemic and occasionally hypovolemic before this all starts. So now you can see the ocean representing vascular failure. We've got a much more forceful ejection from the left ventricle up the beach because we've got a thickened LV, it's hypertrophic, and now it's hitting the wall, which is our stiffened non-compliant aorta, and the reflected pressure wave is coming back with much more force. So the wave's coming up the beach, hitting that wall, amplifying itself, running into the left ventricular ejection, and you can see what happens next as this big wave gets bigger and bigger and reflects harder and harder. It's now completely inhibiting the wave from coming up the beach, and then we get acute pulmonary edema and I get wet. So in summary, the classic vascular failure patient makes up most of the acute emergency presentations. They will be hypertensive at presentation. The chronic heart failures will be relatively normotensive, and remember the cardiogenic shocks will be hypotensive when they arrive. These patients have a normal ejection fraction, and so they're labelled as the heart failure preserved ejection fraction, HF-PEFs. So a very quick summary of management of the acute decompensated heart failure patient. Remember, no morphine. Morphine has been proven repeatedly to be dangerous in patients with acute heart failure. It makes sense. They're hypoxic. They're agitated. Why are they agitated? Because they're hypoxic. What does morphine do? It tells your brain not to breathe as much. What does that do? Make you not breathe as much. What does that do? Makes your hypoxia worse. Does it make your agitation better? Well, it stops you caring about dying. Let's not give morphine, please. Remember, it's not a very good vasodilator. Of course, everyone who's sick with acute pulmonary edema should really get CPAP if you have it, because it reduces venous return, therefore preload, by increasing intrathoracic pressure. It also reduces LV afterload by changing the transmural left ventricular pressure. For the patient who comes in with the chronic heart failure, remember they are fluid overloaded. You can immediately help them by giving some GTN, which mostly is a venodilator and will reduce the preload straight away. And you can give them some furosemide, but don't overcook it with massive doses, which will make them hypovolemic and then worsen things considerably. And for our vascular failure patients, remember they are not volume overloaded. I'll say it again, they are not volume overloaded. They have an acute, essentially hypertensive vascular crisis. The treatment for these patients is to dilate them. Start with GTN, stick it under the tongue, put a patch on, start an infusion. If that's not working because it's predominantly venodilating them, start a more advanced arteriolar dilator. You can give them hydralazine. You could start a SNP infusion, for example, but usually these patients get better with CPAP and GTN, and please don't give them furosemide. Their mortality does increase. Right, so that's it. I hope that the tenuous link I managed to draw between surfing and heart failure has allowed you to get a lovely visual representation of how the different pathological processes happen, and so you can recognize the different patterns in your patients and manage them appropriately. I'll say goodbye with a photo of me about to get completely mashed on a closeout on a Sri Lankan reef, and I really look forward to seeing you next time on TiCME.